Peter. So I now call on our Chair of the Day, Rosemary. Thank you.
Jeremy is an obstetrician and gynaecologist whose career has spanned academia, clinical care, and medical administration. Graduated from the University of Adelaide in 1968 and worked in Papua New Guinea prior to specialising in Nottingham in the UK. He's had senior academic and clinical appointments in Victoria, Queensland, and the Northern Territory, with multiple roles, particularly to do with obstetric and paediatric mortality and morbidity. And with these roles, he's been involved in a review of pregnancy outcomes for mothers and their offspring in both Victoria and nationally. And as we all know, he's been the driving force in the Rotary program to upskill midwives and doctors in Timor-Leste, where there was previously a horrific maternal death rate. From 2011, he visited Timor-Leste over 20 times with a group of volunteers for over a week at a time to deliver upskill training. I've seen a number of 578 attendees, presented presentations and practical demonstrations with interpreters in the local language. He's a multiple Sapphire Paul Harris Fellow, as well as receiving Rotary Service Above Self Award, the highest honour for all his work in East Timor over decades. He's received multiple non-Rotary awards, including a member of Order of Australia in 2022 for significant service to women's health as a clinician and academic. And despite this CV, it doesn't say anything about his wonderful role, amazing job in delivering my daughters. You did a great job. He's going to talk to us about free birthing, pros and cons, and tell us all about it today. Thank you, Jeremy.
While we're getting organised, I do want to pay tribute to Ian Ross, who's on Zoom. Ian was my nominee when I returned from Queensland to rejoin the Rotary Club in Melbourne in 2002, and he's been a very important mentor and supporter during the time, and I owe Ian a lot. So I'm sorry I can't see you in person, but great. Also, I do need to declare a conflict of interest with Rosemary Nixon. Despite my very best efforts for advice that she should really free birth, she declined. I've been asked to talk about free birth, which by definition is when a woman makes a conscious decision to give birth without the support of a registered health professional, such as a midwife or doctor. And I think many of you will be aware of the recent maternal death of a woman who free birthed in Melbourne. And it really drew attention to this practice and highlighted the risks to both the mother and baby when complications arise. So by way of background, it's a brief overview of the history of maternity care in Australia. Of course, until the early 1900s, a high proportion of births were at home, increasingly with the visiting midwife, and I suspect a high proportion would have in fact been effectively a free birth because they would not have had an attendant there. Medical specialist involvement gained momentum on the 13th of February 1929, so it's almost just the anniversary, which was the formation of the Royal College of Obstetricians and Gynaecologists. And of course, Australia, being very much part of the UK at that time, specialists in Australia were fellow or members of the Royal College of Obstetricians and Gynaecologists. And it wasn't till the late 70s that, in fact, the Australian College got going itself. And the RCOG took responsibility for the education, the certification of specialists and standards of care. Until the 1980s, midwifery education was basically maternity hospitals. Sorry about that. I think we're just about ready to go. So until the 1980s, it said midwifery education was basically in the maternity hospitals. And after that, there was an increasing transfer to the universities when that started from then. And of course, now all the education of midwives is within the universities, and so it's being a degree, not a really effectively a diploma course from that. And the College of Midwives is also very much involved with standards. So looking at about the fertility and the Australian situation. So in the last 50 years, the population of Australia has gone from just under 14 to almost 27 million. So, a doubling of the population. Women in the reproductive age group, which is defined as between 15 and 49 years, there are estimated 3.2 million in 75 and 6 million in 2025. The number of births in that time has increased, but of course, and you'll see in a moment about the fertility rate, from 233,000 to 292,000. Now, the fertility rate is calculated by the number of births divided by the women in the potential childbearing age group or fertility. So 1975 was 2.15, and now it's fallen to 1.48, which is just about, in fact, it's below the natural maintenance of the population, hence why we do need immigration. From getting actual figures of the workforce has been a little bit more problematic because there's been surprisingly little publication of these, but in 75, there were 825 specialist obstetricians. There are obviously GP obstetricians, but figures are not available for that. And then these are GPs who've done additional training in obstetrics, and then the associate GPs who work within that. Again, those figures are not available in 1975, but by 2025, there's a big increase in the number of obstetricians to 2,400. When you look at the number of births, there's an interesting balance, although quite a few of those would be doing not primarily obstetrics, but would be also doing gynaecology. And then the GP obstetricians, were the 450 were registered, and associate GP obstetricians, 2,500. So doing particularly antenatal care. Midwifery figures are more difficult to get. The figures are not available that I could find before 2015. So 2015, there were just over 33,000. In 2025, 36,000. But then again, you look at the number of births associated at that time. But those practicing midwifery only, again, was not declared in 75, but in 2025, 6,785. Now, one of the issues with midwifery, of course, is the ageing workforce and the reduction in the number of women doing, people doing midwifery, because, of course, there's now a significant number of males also doing midwifery. So what about the site of birthing? Well, currently, 95% of women give birth in a hospital facility, 3/4 of these in a public hospital and 1/4 in the private hospital. Home births have certainly not increased, were not well recorded in probably before 75, but 5% now in Australia, women are giving birth at home, and that is with a qualified midwife and or a doctor being involved in the care and also in the birthing. Free birthing, there aren't good figures. So quite a few don't declare. So we don't know what the overall figures are, actual figures for Australia, but it is a small number, estimated between 0.5 and 1, but I would think probably closer to less than 0.5. Now, the issue, of course, we are getting to talk about free birthing and safety, but I think it's important to look at particularly concentrating on what's called low-risk pregnancy. That's women without defined complications, and come back a little bit more about that in a moment. There was a big study done in high-income countries and published. There were 28 studies reported from 14 countries. They're able to compare the outcomes of women who gave birth in a planned home birth and compared with those who had a planned hospital birth. Some of the planned home births, of course, did end up being transferred into hospital for complications. But of those who had a planned home birth, 91% of those had a normal vaginal birth, normal birth, compared with those who gave birth in a hospital, which 54%. And this is low-risk pregnancies. It's not all pregnancies. Caesarean section rate, where, of course, for the home birth would have been transferred into the hospital for that, 2%, the planned home birth, 9.7% low risk having a caesarean section in the hospital. And the relevance for this for the home for free birthing I think will become fairly obvious. Those with an intact perineum, that is not having an episiotomy or a tear, were comparable between home birth and hospital birth. Severe perineal trauma, which is where there is disruption, particularly at the tissue leading back into the rectum, so which has quite some significance, long-term significance. Postpartum hemorrhage, yes, that was greater in women who gave birth at home. So, where that came from?
It might not be.
AI, I think.
Might not be.
It might not be moved,
Disputing what I'm saying. Compared with 1.6 now, and then admission to the neonatal intensive care unit. Right, okay. Admission to a neonatal intensive care unit, those with a planned home birth, low risk, 0.24%, so very uncommon. And also in the hospital birth, less than 1%. But the important differences, obviously in the normal vaginal birth, and which was much higher in the planned home birth, lower caesarean section, lower instrumental births being a third, and then the only one being the high rates of postpartum hemorrhage. Of importance, there was no significant difference in stillbirth or neonatal deaths in the 102,000 who had a home birth and the 336,000 who had a hospital birth. So from a safety point of view, in fact, those with a planned home birth attended by a qualified, well-trained midwife with good backup from a hospital service so they can be readily and easily transferred. So I think when we're looking at the free birth, this is really the group that we need to keep in mind rather than the actual hospital. What also though is important is that those having their first pregnancy, 40% were required transfer to higher care hospital care, but only 10% of those who'd had a birth before. So certainly for women who've had a previous pregnancy, which I guess has really tested their pelvis and their uterus and other important parts in the delivery of the baby, do very well, but 60% of those who prime-eps can give birth very safely in the hospital. Now, turning to caesarean section, because caesarean birth is obviously a major issue, especially when we're considering birthing outside the hospital environment. And the difference in rates between home and hospital is a major influence on where women decide where they wish to birth. And as you can see that the rates have really changed. You know, when I first started doing obstetrics in about 1822. The rate in 1975 was 5%. So it was quite uncommon, relatively. In 1980, it had gone up to 16. There was a steady increase through the 90s. By 2011, it was 30%. 2020, 39%. In 2023, 41%. 4 in 10. And then the big difference between women who are having private care were almost half delivered by caesarean section. In the public, it's gone up to a third. Now, what are the factors that contribute to this? Well, maternal age. There's certainly been an increase in maternal age. If the baby is presenting as a breech, there was the term breech study, which showed that the outcomes were a little better for those who had a caesarean section. So, and this came out in the 80s, and fairly quickly, the schools required for delivering a breech really disappeared. And so the very strong pressure for a person with a breech to be delivered by caesarean section. And I guess conflict of interest there. My daughter, who was born in England and presented as a breech, the two boys who were born in Australia came as a vertex. So I'm sure it's got to do something with gravity or the way the water goes down the sink there. But as the professor, who was Australian in Nottingham, as delivering the breech, and I was asked to hold the legs, came and said, ironic Oates, I should demonstrate how to deliver a breech on your own daughter. But those skills have certainly diminished. If the baby's lying acrossways or other malpresentations, obviously there are problems with delivering vaginally, so caesarean section. Induction of labour, most commonly for being post dates, but also for other obvious complications, medical complications, and increasing obesity. Part of the problem issue too with induction of labour, there have been a series of papers that purported that the outcomes were much better if there was routine induction of labour, even at one stage from 38 weeks. And that occurred, that paper came out, in fact, when I was working in England, and it really changed. There was a lot of pressure because it came from Oxford. It really changed the advice that people were given. And I think that it settled back a bit. Prematurity, yes, and birth weight, more than 4,000 grams, certainly because of the obstruction issues. So does this explain the rising rates and the public-private difference? Roberts and colleagues from Sydney published data in 2012. And what they did was they looked at the actual caesarean sections rates and they adjusted for all these contributing factors on what was happening in the background population. So the predicted caesarean section rate, taking into account those factors we just talked about, you can see there's a mild rise in the Caesars going up, but here's the actual caesarean section rate going up. So obviously other factors. I mean, the thing I haven't mentioned is the medico-legal issues, golf days. No, won't go into that. But also, I think fear from both the recipient and the doer. And this has had quite a big increase in women asking to have a caesarean section as a matter of course. So all these factors are having an impact on choice of birth. So when we look at the reasons, this was done from a study in Australia where they interviewed women who had elected to have a free birth or were wanting to. And the reasons that they gave for their choice of free birthing was, quote, their knowledge about what was best and safest had greater authority than the socially accepted experts in maternity care. Puts us in our place. The biomedical approach to childbirth was riskier than giving birth outside the system. And particularly the previous birth experiences, that the hospital was emotionally unsafe and the risk of further trauma if they returned to hospital. So this is particularly in women who'd had caesarean sections or had had quite major perineal trauma, but also they felt psychological trauma, that the staff did not listen to them. They weren't given the opportunity to be heard, basically. There are a number of reports of women having operative deliveries without really giving verbal or written consent. So, you know, an undercurrent, hospitals being busier and feeling rushed by this. Now, well, what are the risks in free birthing? For those who totally elect not to have any medical supervision, so they do not have any antenatal screening. So for the infectious disease like syphilis, etc., which is on the rise, of course, rubella screening, Hep B, HIV, all of which can be treated and monitored, CMV, genetic disorders, so prenatal screening for including Down syndrome, having a blood test done to check their iron levels and diagnose anemia so that they can be given iron if needs be. Blood group, including rhesus, so women who are actually rhesus negative, the opportunity then to have anti-D to prevent sensitization. And so, of course, the antibodies crossing the placenta and affecting the baby don't have that. Urinalysis, which is recommended as routine for looking for protein. It's a marker of underlying kidney disease. Ultrasound, first of all, for accurate calculation of gestational age, for looking at congenital anomalies. Many of them say they would not have an ultrasound. Then during the pregnancy, watching fetal growth. So again, ultrasound being helpful for assessing fetal growth. Screening for diabetes, gestational diabetes now affecting over 20% of women in Australia, related to population changes, but also to maternal obesity and maternal age, and monitoring the blood pressure and diagnosis of hypertension, which has quite significant effects on the growth of the baby and also can cause quite major complications in the mother. So, effect on pregnancy care, the issues there, antenatally, if there's no trained medical midwife or doctor having a proper assessment of their health and their past history and conditions that are likely to affect the pregnancy, both for the mother, but particularly for the baby. Not accurately measuring fetal growth, so by if they're not having any, by palpation by a skilled person, measuring blood pressure, watching and advising if there's excessive weight gain and particularly weight loss, which again is reflecting or has the impact on affecting fetal well-being and how the baby will cope with the labour. During pregnancy, no monitoring of blood pressure, no monitoring of the fetal heart rate. May note fetal movements, but they're an indication, but not that reliable. Not measuring maternal temperature for diagnosis of infection, and particularly no monitoring of the progress of labour, so to be able to determine when labour is not progressing it satisfactorily, and which of course will have quite an impact both on the baby and the actual delivery. Then in the birthing, actual birth, monitoring the progress by a skilled person. If there are problems delivering the shoulder, so-called shoulder dystocia, interesting, just reflecting on our teaching in Timor-Leste, all these things that we spent a lot of time talking about and upskilling on. And then the delivery of the placenta and hemorrhage. And not as a routine course, women are advised to have an injection of a medication that makes the uterus contract and substantially reduce the impact of hemorrhage, which has not only an immediate effect, but also does affect the woman in the days and weeks after delivery. So these are the issues that if a person elects to have a free birth, that they are potentially not able to access or do not want these to be done. So where's the source of information? There's quite an extraordinary article, the amount of work, which was published in The Guardian on the 26th of November, into the Free Birth Society, which is a society based in the US, but has subscribers, as you can see on the bottom, yet large in the US and Canada, but also really around the Western world and also into Southeast Asia and South Asia, Switzerland, France, South Africa, Thailand, India, Australia, UK and Israel. And in that, in a very brief summary, it's about a 20-page article, there were 48 perinatal deaths that they looked at. One woman who went temporarily blind after 4-day labour with severe preeclampsia, and when she went into the website, I was told that was a normal thing. It would get better. Don't worry about it. Then the number with the baby, because often they were showing a video of it to share amongst the Free Birth Society, with the baby showing obvious signs of breathing problems after birth, and being told by the people on the line, say, oh, this is quite normal, and no, resuscitation, the baby knows what it should be doing. There was one of them, as detailed there, as a 23-year-old Australian mother in her first pregnancy, had no antenatal care. She posted online in labour, she'd been in labour for 5 days. And the response was, oh, that sounds so normal and so hard, but the baby's coming, you can do it. Day 8, she was still going. Day 9, in labour, there was evidence of St. Bandrel's ring, which is a ring that you can palpate in the uterus if it's obstructed. This is a band of uterine muscle. The baby was eventually born. The video showed it to be grunting, and she said, is this normal for a newborn? There was no response from the people who run it, and the baby subsequently died. So the influencers of that are actually multimillionaires. They have made an enormous amount of money in promoting the free birthing and to join the Free Birth Society. So I guess this is, the reason we're on about this is concern about the balanced information and we're the source of the balanced information. So solutions. We know that team midwifery, where there's a known group of midwives caring for the mother, both the low and the high risk, really improves outcomes, reduces interventions, and certainly increases satisfaction. We've talked about the home birth option, the low risk, particularly after the first pregnancy, where, of course, they are looked after by very skilled and experienced midwives. From the hospital's point of view, communication comes up as a major concern. And so improving the healthcare providers' communication skills, and especially for those that English is not their first language, explaining what is happening, why something needs to be done. The stories about, women having vaginal examinations to assess progress, yes, it may need to be done, but to explain why it needs to be done. The active acknowledgement and respect for maternal autonomy. Of course, the baby is not an individual in law until it's born. So the mother has absolute right to refuse care, even if one is concerned about what's going to happen, but respecting that autonomy and working with it. The importance of evidence-based practice for interventions, and really important too, the debriefing and support when complications have arisen, to spend time with the mother and the father and the family, if needs be, to explain what had happened and why it happened, what they are likely to expect, and what may happen next time and how that will work. And very important, because of the aging midwifery cohort, the need for increasing the number of midwives and making life more pleasant for them and retain them. So, free birthing. I suppose, yes, Rosemary, it was a good decision of yours not to have a free birth. But clearly, big problems. But I think the challenge is to the providers of maternity care to be aware of what the issues are for this group of people, to improve communication, improve education, and then hopefully the bad and tragic outcomes for some of them can be avoided. Thank you.
That was really, really interesting. While we're waiting for questions, question without notice. So I'm not a grandmother yet. I'm waiting, still waiting. Their respective careers, but I have heard that there's a significant decrease in fertility in particularly men, but also in women, but particularly men over the last 30 years. Is that true?
I certainly have seen those reports, yes. Yeah. So leaving births to later, although I must say I was a little concerned going past a tram yesterday, and on it had a big advertisement for egg freezing.
On the tram?
On the tram. Company that's doing that, I do struggle with that.
Bruce.
Bruce Livet. I only wish that my dear departed wife, Diane, a triple certificated nurse and midwife who trained at the Alfred at the bed, this was prior to having college training, was here, because she would have been fascinated by the data you presented and also have many more questions for you than I have, but I'll try and guess a few for her. When we moved to Montreal for my work, my wife was very keen to continue her midwifery, and she was a bit shocked to find out that she could do everything up to the point of delivery, and then an obstetrician was brought in. And she said, well, Bruce, it's time we had our own family. So her experience with that, and we had a boy first and then 2 years later, a girl. And they were both delivered by cesarean section because she was 33 and there was some complications. But she really believed that it would have been her preference would have been to have at home, but it was the middle of winter, and the middle of winter in Montreal is not a nice place. So she had it both at Montreal General Hospital, and she always thought that the training that she received at the Alfred bedside was much more appropriate than the experience she had in the delivery ward, and once again, communication is, a problem. I was interested that you said that blood group was a factor. She was O negative, universal donor. Was that a factor also in delivery?
So the rhesus negative.
It's only, I don't know the rhesus.
Yeah.
Yeah, that she was a universal donor called in when O negative, I think, is the blood group.
She would have been.
Yeah.
Yes. Yeah.
Yeah.
She obviously picked the right partner.
Thank you.
Very quickly, Jeremy, years ago I discussed with you, you said you didn't make any money because of professional indemnity insurance. What are the complexities of professional indemnity insurance with home birthing and then being transferred to a hospital and so on? Is it quite complex?
Well, in fact, it depends whether it's public or private. There is, I didn't mention that one of the, I think, real improvements from the home birth was started in the late 1980s, was publicly funded home birth, which is done in conjunction with the hospital. So that's not an issue about indemnity on that. You're covered by the hospital, yes. As the other, I'm not sure what the issue is, whether I'm not aware of, if you get involved with the home birth as an obstetrician, I don't think that affects you. You're covered on that by your, it doesn't affect your premium as far as I'm aware.
Hi, Jeremy. Joseph Ebbich here. Just a quick question around health influences, which just seem to be gaining more and more impact, some positive, a lot negative. Within the health profession, what should be our next steps?
Fortunately, I've retired. It's how you chase the rabbit hole issue. I think it's hopefully in the contact with the woman, preferably before pregnancy, but during earlier pregnancy, is getting the right information sympathetically out. So you can, I think, help with that. And if somebody's raising the question, about home birth, for example, particularly if they are low risk, talking that through, checking about the transfers and things like that, but getting that information out beforehand. I mean, how you deal with those sort of influencers that the Guardian's talking about that really is quite chilling reading that. And I read some of the best stuff, not the worst.
Thank you very much, especially for the interesting data. I know that in Germany, especially violence while giving birth is a big issue. I think every third woman is experiencing violence while giving birth, and that's one of the major issues in our system. Are there any data sets on that here in Australia? Because I generally don't know.
There's certainly been an inquiry on that, so it's been published. Part of the issue too is what's defined as trauma, and that has been a problem. Recognizing what, if a person does need a cesarean section or does need an instrumental delivery, and is that trauma as such, and if persons don't have, so it's not an easy, not like, oh, there's a cut, that's trauma, or you've been, broken your leg. It is complex. So I can't answer your question. Sorry.
Thank you. Well, it's fantastic to have heard that presentation. Thank you so much, Jeremy. Don't go away. So one more round of applause, please. And we do have, of course, some Rotary socks. You won't be surprised that they're fantastic, 200% Australian philanthropy socks. Both of them. Thank you. 600. Oh, gone up to 600%. Thanks everyone for coming. Thanks to Bernie and MC and past President Peter Dakin for his reflection, and setup team, reception, staff for their efforts. Reminder that next week's meeting is here at number 35. Our guest speaker is Alberto Balbo, renewable energy consultant. Please look to the bulletin and website for further information.